And why don't we get started? Welcome to Psychiatry Grand Rounds. My name is Tony Rothschild. I'm chair of the Grand Rounds Committee. Just a couple of brief announcements. When you signed into Zoom, you have signed into Grand Rounds, but in order to receive education credits, please fill out the SurveyMonkey evaluation form that was sent with the Grand Rounds announcement on Monday by Karen Lambert. Grand Rounds will be on Zoom for the rest of 2021 and January and February of 2022, but we are tentatively planning to have Grand Rounds back in person in March of 2022, but of course it will still be available to the audience on Zoom. If you have questions for the speaker, please type them in the chat function, and Dr. Yonkers will ask the speaker the questions at the end of her talk. Next week is Thanksgiving, so there are no Grand Rounds. The next Grand Rounds will be on Thursday, December 2nd. The speaker is Dr. Amalia Lantono Toban from Brown University. And the title of her talk is Racial Implicit Associations in Psychiatric Diagnosis, Treatment, and Compliance Expectations. It's my pleasure to introduce Dr. Kimberly Yonkers, who is the Katz Family Chair of the Department of Psychiatry and Professor and Chair of our Department of Psychiatry, who will introduce today's speaker.
Thanks so much, Dr. Rothschild. So everybody knows me, but it's my distinct pleasure to introduce Dr. Kathleen Brady. Dr. Brady is the former Vice President for Research at the University of South Carolina, Medical University of South Carolina. She is also the Principal Investigator and Director of the Clinical and Translational Science Center at the Medical University of South Carolina. She's a distinguished professor at the Medical University of South Carolina, and she also is the PI of their substance use, sex difference in substance use score. And I think that is the longest lasting score under that particular venue. So she and her group have just made absolutely spectacular contributions to the literature on that area, as well as other areas. She's a clinical and translational researcher with greater than 30 years of experience. She is also the author or co-author of more than 400 publications. She's focused on the development of new treatments for individuals with substance use disorders. And she really has had a tremendous and lifelong commitment to mentoring and training the next generation of biomedical investigators, including medical students, residents, fellows, junior faculty, the entire spectrum, and has won awards for her mentoring work. Some of her contributions to science include exploring innovative treatments for substance use disorders, including oxytocin and acetylcysteine, rTMS, and real-time fMRI feedback. She's conducted multiple investigations between stress and substance use disorders. Her work shows some abnormalities in the HPA axis and in noradrenergic function among individuals with substance use disorders. Today, she will be presenting on the relationship between stress and substance use disorders. And welcome, Dr. Brady.
Thank you very much for that lovely introduction and for inviting me. It's really nice to be here with you all. Looking forward to a time when we are actually able to be face-to-face again, but and hopefully that'll be in 2022. But in any case, I'm going to talk about something that I really have dedicated a lot. In fact, our score, our gender, sex and gender center is focused on this, gender differences in the relationship between stress and substance use disorders. And just wanted to tell you, this is a picture of beautiful downtown Charleston. If anyone has not been there, it's a beautiful place to visit. When we're allowed to visit places again. Oh my goodness, now this isn't going forward for me. Hang on. It did when we...
You may need to click on the slide one time and it should advance for you.
Okay. Oh, good. So I should click on the slide instead of, okay, got it. For disclosures, I'm a consultant to several pharma companies as well as treatment settings. And want to start by thanking really so many of my wonderful colleagues whose work I'll talk about today: Amy McRae, Sudie Beck, Connie Gill, and all of the work from our group that I'll talk about today has been funded by NIH, by our SCORE, by our CTSA, and our Clinical Trials Network grant. You know, addictions, of all of the illnesses that we deal with, truly is a biopsychosocial illness. I mean, we know it's a brain disease. We know there are brain changes, but there are certainly tons of medical sequelae and consequences of use. The social and environmental factors actually both addictions impacts the social environment, but the environment in which people live and breathe and work also impacts their vulnerability to addiction. And certainly we're all aware of the economic impact of addictions. It's pretty profound. And in fact, I guess you guys saw the New York Times headlines yesterday: more than 100,000 deaths from opioid overdose in the last year. That's the highest number we've ever recorded. But that's a subject of another talk completely. Anyway, and so one of the big questions with addictions that's always come up is it nature? Are people born with this gene or vulnerability to addictions, or is it the environment that that they live in that actually makes it impossible for them to resist the urge to use in an out of control manner? And there's been back and forth in this topic for many years, and especially when you talk about this stress substance use relationship, it's kind of important because you interview people with addictions, and many of them will tell you about traumatic exposures in their lives. But often what they talk about are things that happened after they started using. So the whole which came first, were you hanging out at the wrong place, in the wrong place with the wrong people and ended up getting beat up or worse? Or is it that these traumatic things that happened to you have led you to, in some ways, to attempt to use drugs and alcohol as a way to overcome some of the painful memories? One of the things we know is these traumatic, and most studies will tell you people in treatment. So people in treatment are your most severe people with addictions. Somewhere between 70 and 90% have traumatic events at some point in their lives. A fair number of them have childhood trauma, and this is particularly true for women. So in that case, it does make you wonder, well, was the trauma pre-existing, and is the development of the addictions in some way a compensatory attempt? So this whole idea that there's a stress addiction connection has intuitive appeal. Patients will tell you about it all the time, not only how the stress led to their addiction, but also how it leads to relapse. Well, doc, I was doing great, and then my wife left me, or I lost my job. Dig a little deeper, you find out their wife left them because their drinking had continued, or they lost their job because they never came in on Monday morning. So, it's kind of a conundrum there, which came first, and the causal relationship can be actually pretty difficult to establish. But a couple of things we know for sure. One is that childhood adverse events, and I'll show you some of this data, but there are many, many, many studies that indicate this, are very strongly associated with the development of substance use disorders. In fact, in some of the larger studies, like Ken Kendler's twin studies and stuff, childhood sexual abuse, it had the strongest association with the development of alcoholism and drug abuse. It's associated with childhood abuse is associated with a lot of other bad sequelae in adulthood, depression, PTSD, other things, but the strongest connection is with addictions. And that's what we decided we wanted to explore the neurobiology of. And the other thing we know is that PTSD, mood and anxiety disorders, these sort of stress-sensitive disorders, are also very strongly associated with substance use disorders. And these disorders are 2 to 3 times more common in women. PTSD, of course, is like the main disorder we think of when we think of stress-related disorders, because the stressor, a traumatic life stressor, is essential to the diagnosis. And we know that in treatment-seeking individuals, probably 30 to 40% have a substance with PTSD, 30 to 40% have a substance use disorder, probably higher in combat-related PTSD. And when you think that substance use affects 5 disorders, maybe more like 10% of the general population, that means this group is at significant risk. In substance using samples, depending on where they, if it's men or women and how long the course of recovery, estimates of trauma are extremely high. For women, it's probably 70 to 80%. Also very high in cocaine and opiate users. And in all the epidemiologic survey studies, that ECS, the NCA, all of these show that PTSD, there's a very high odds ratio for these 2 disorders to co-occur. So you figure it's probably not a random association, and there's something causal going on there. And there's a lot of levels at which that causality can be occurring. But what I want to talk about today is really the neurobiology. One of the things I want to talk about is the neurobiology of the stress response and how that interfaces with substance use disorders. And when we think about that, there's a lot of systems involved in this response to stress, and a lot of systems involved in drug abuse. And all of these, the ones that I'm going to talk about are the ones that we've measured and that are easier for us to measure using our human laboratory paradigms: the HPA axis, extra hypothalamic CRH, and then the locus coeruleus, a fight or flight noradrenergic system, dopamine, serotonin, GABA, glutamate, all involved in the stress response, all involved very, very much so in the development of addiction. And we're going to talk about some drugs that act on those systems that may be useful in people that have this stress-induced relapse or stress-induced substance use. So just to review very quickly, HPA axis, I know you guys are all very familiar with it, but CRF or CRH, corticotropin releasing factor or hormone, goes to the pituitary, where it causes the release of ACTH from the anterior pituitary. At the same time, though, beta endorphins and other drugs that actually are tamp down the stress response are released from the posterior pituitary. That the ACTH stimulates the adrenal glands, and you have an increase in cortisol release. That peaks at about 20 minutes after the stressor. The more immediate response really is CRF going directly to locus coeruleus and stimulating the release of norepinephrine and epinephrine from the adrenal cortex. So that is the immediate response. And one of the things cortisol does is come up behind and sort of shut down the system, because you want a good, robust system. And that's one of the things I want to emphasize, because you'll see that's not what happens in our people with drug use disorders. You want a system that responds real quickly and then goes back to normal quickly. So you're not on hyper alert and overdrive all the time, even when you're not threatened. That would be a bad thing for homeostasis. So one of the nice things, and our score is actually, like most scores, we've got basic science and clinical projects, our human laboratory projects. And so some of this data I'm showing you right now came from our score. But there are beautiful, one of the things about substance use disorders is we've got really nice animal models, and partly because it's easy to measure, we've got a great endpoint. Animals will drink alcohol and take drugs, and they can do it to excess if you especially make the circumstances right. And then you can look at things that interfere with it. You can look at the neurobiology of it. And there's 3 main models of reinstatement or relapse that we use. One is, so you get the animal addicted to the drug, they get physiologically dependent. This could be cocaine, morphine, alcohol, you name it. And then you take it away abruptly, so they're in extinction. And then you do something to the environment and look at how quickly they go back, resume their drug taking, or try to resume their drug taking, press the lever that's associated with drugs. So the three things you can do is you can show them environmental cues that were always associated with having the drug around. You can give them a little taste of the drug, sort of like, and then they will go right back to the lever and start pressing, or you can stress them. So stress-induced relapse, and that stress, it could be foot shock. You can make them swim in a little bowl, but rodents don't like to do that. All kinds of stressors, and put them back in the environment where they used to use, they'll immediately go to the lever and start pressing. And so, you can imagine these actually have a lot of heuristic value. I mean, one, we all know when people see environmental cues associated with their drug use, they'll salivate, they're tempted to use. We also know that everybody knows that story. If someone says, well, I went to the wedding, I was just going to have one drink. As soon as they had a sip, they were off the wagon. And then we all know people that talk about stress and relapse. So as I said, a variety of stressors, foot shock, isolation, forced swim, variety of substances have been shown with this: heroin, cocaine, alcohol, nicotine, and pharmacologic and surgical manipulations actually show distinct circuitry between these three models of relapse. And in particular, stress-induced relapse is blocked by things that interfere with the adrenergic system. So beta blockers or alpha blockers. It's also blocked by CRF antagonists. It's precipitated by CRF agonists. It's precipitated by adrenergic agonists. So we know it's this, it's the bed nucleus of the stria terminalis, it's the noradrenergic systems, and it's the HPA axis that are involved in stress-induced relapse, also very involved in PTSD. So one of the things that we do as part of our score, we have human laboratory studies, and we bring people in. Usually we have people with, it could be cocaine. We've done this with cocaine, opiates, alcohol, and nicotine. We usually do, and then a control group, usually age and gender matched. There's a number of different types of stressors we might use. We might use a psychological stressor like the trier, where they have to speak in front of a group of strangers. We might use a physical stressor like the cold pressor, or a pharmacologic stressor, actually give them CRH or give them yohimbine. Sometimes we'll expose them to, just depends on the experiment. We've done this, as you can imagine, many times over the last 30 years with different drugs and slightly different paradigms, depending on what the experimental question was. And then we measure craving, we measure stress, we measure ACTH and cortisol, norepinephrine, epinephrine, and other physiologic parameters, heart rate, blood pressure. I am not going to show you a lot of data from all of this. I'm going to show you some exemplary data and then ask you to trust me when I tell you that some of these findings, not all, but some of them have been consistent across substances, particularly where we have seen gender differences. And so this is a study published a couple of years ago, cocaine-dependent individuals in a control group, men and women, equally matched, given a low dose of IV corticotropin releasing hormone. And what you can see, the graph on the left side is craving. You wouldn't expect people, this is only on a 1 to 5 scale. You wouldn't expect normals to crave no matter what was going on, and they don't. But you can see CRH, again, this is a peptide that's circulating in our bodies, actually causes craving in cocaine-dependent men and women. And CRH also causes the second graph is just stress and anxiety. And you can see a little bit of CRH because it is a stress hormone. Both men and women in the control group show a little bit of activation, but you can see that activation. So our cocaine-dependent males and females appear to be somewhat sensitized to CRH, or this stress hormone, or a stress provocation. If you look at the relationship between ACTH and cortisol, because one causes a release of the other, it should be close to 1-to-1. And you can see in your control males and the control females, which is the graph on the right. Now, they have a fairly good correlation, but you can see with cocaine-dependent men, significantly less correlated, so showing disruption in some of the feedback loops in this HPA axis. And if you look at the cocaine-dependent females, there's absolutely no relationship between cortisol and ACTH release, and their cortisol levels are actually quite low in spite of the higher ACTH and CRF, producing a stress response. Because we go back and forth, we have this iterative process with the with our basic science. This is Ron C. and his group. We said, we think there's gender differences in this response to CRH in our cocaine dependent. So they went and did this in females. Female and male rodents. We knew CRH would provoke reinstatement. That's what we're looking at, lever responses. The first set of bars is in the extinction condition. Animals don't think they're going to get anything. They're not pressing. Then you give them CRH, and you can see both males and females in a dose-dependent way. CRH provokes behavior that we would consider drug-seeking. This is our model of relapse. But what you can see is it's CRH is stronger in in provoking this response in the female rodents than the male. So this was the first time that had actually been shown that there was this gender difference in the stress in the stress relapse response. We also saw, because we measure heart rate, a big difference in the heart rate. So heart rate goes up when you give CRH, even in normals. That's the two lower graphs. It goes up in your cocaine-dependent men a little bit, and then normalized. Look at the cocaine-dependent women. That's the top bar with the circles, and you can see the heart rate goes up an awful lot more, and it stays up. It doesn't normalize. This is over 2 hours. 2 hours after they receive the CRH, which is a peptide. It doesn't stay in the system very long. So you can see they get all keyed up, and then they don't calm down. I mean, they just don't their HPA axis and their noradrenergic response just seems to stay high. They're sort of on edge. And we have shown this same thing, particularly with the heart rate. The heart rate makes us think more about the noradrenergic system, that there's going to be more noradrenergic sensitivity in this woman, because this is an immediate acting response. As you can see, it's at time 0 that the heart rate goes up. So that's an adrenergic response. So we have shown this in opioid dependent women. This is cocaine right here. We've shown it in opioid, nicotine, and alcohol dependent women, the same sort of differential in terms of noradrenergic sensitivity. And so one of the things we went on to do was look at, okay, what if we take something that provokes the noradrenergic system very specifically in this same group? Yohimbine is an adrenergic agonist, so it without the CRH part, this just acts on the adrenergic system, and this is in cocaine-dependent men and women and controls. And what you can see is the high bar on both of these is our cocaine-dependent women, that they show much higher craving and much more anxiety when given yohimbine as compared to their cocaine-dependent males. And the males have a little bit more sensitivity in the controls. So there's dysregulation. There's more response to adrenergic stimulation. Is there any relationship between this dysregulation in the stress response and relapse? Well, yes. So we take this data after people do the human laboratories paradigm, they come back a week and a month later, and we'll ask them, how much did you use? What do you in drug screens? And ask how much they used and under what circumstances. And what we've found is that in alcohol, nicotine, cocaine, and now opiate dependence, greater dysregulation of that biologic stress response or failure to normalize during a period of abstinence. And this is not just our work, but work of many others, are both associated with a greater risk of a relapse, and perhaps with a greater risk of developing PTSD if somebody is traumatized. That's something that is fairly speculative, but so I sort of hinted at the fact that we found some really interesting gender differences here. But even before we were working on the biologic systems, there was a lot of literature and some of our human laboratory stuff that indicated that women will crave much more to, and this is not just laboratory studies, but a lot of survey studies of people in treatment asking them, what are your relapse triggers? Women generally report greater craving to negative emotional cues compared to men, both in a laboratory setting and just in self-report. Women are much more likely to endure stress and interpersonal conflict as the relapse precipitant than men are. Men are much more responsive to drug-related cues, environmental things. I went out, with the gang after playing golf, and I just thought I'd have one beer, or I ran into my dealer on the corner. And so there were lots of human laboratory and other survey type studies suggesting this. And then Mark Potenza and the group at Yale did a beautiful study. I think this is comparing cocaine dependent men and women with a healthy control group. And we're looking at what lights up when under two different MRI situations. One is where they are read a stressful narrative. It's a personalized narrative from a stressful situation for them. And the other is they're shown cues related to their drug use in the scanner. And what we're looking at the left side is women. And this is where cocaine dependent women light up versus the healthy controls. Right side is men versus the healthy controls. And what you can see is beautiful activation with the stress related cues for women in all those areas we know are associated with drug abuse, all that midbrain, nucleus accumbens. We'll also see some hippocampal activation, again, sort of memories associated with this stress. If you look down here with the drug cue, there's just not much activation. For men, it's just the opposite. Stress cue, little bit of activation that's above and beyond what you see in the controls. But boy, look at the activation with the drug cues. Again, same areas. This actually in these men, it's more in these limbic sort of hippocampal area where sort of the memory of the drug cue and is retained, and that's the area that really gets activated with cue-induced reinstatement of drug use. So that was a very nice study that sort of summed up what a lot of us had been looking at in other ways. So conclusions in terms of this neurobiologic interface is that chronic stress, as well as substance use disorder, pathophysiology involved similar changes in key neurobiologic systems. And there is likely a feed-forward system that worsens the symptoms of both disorders when people do have both, let's say, PTSD or are in extremely stressful situations, and they have a substance use disorder or a vulnerability to one. One little sidetrack I just wanted to talk about was this childhood adversity. I brought it up earlier, and clearly, if it's childhood adversity, it's going to predate the onset of the substance use. So that's what takes that whole question out of the equation. Tons of clinical reports. I mean, every study that's looked at childhood adversity and what happens into adulthood, addiction is a big sequelae. And studies in treatment-seeking individuals suggest very strong relationships, particularly for women. And this was a great study. This is probably, it I think rivals the Framingham Heart study in terms of the number of publications. There must be hundreds of publications from this adverse childhood experiences study done way back when, 20 years ago. But basically, they took a very large sample of people and asked them retrospectively. At this point, when we first read this study, we had really just been looking for the most hideous things. Were you beaten up and ended up in the hospital? Were you raped or touched in any way that was uncomfortable for you? But what was interesting about this one is that the adverse childhood experiences scale is much more nuanced. Did you move a lot? Was there alcohol and drug use in your home, so it actually was able to give you sort of a cumulative, if there's a cumulative effect of multiple small stressors, as well as they do certainly ask about the big things, the sexual abuse and physical abuse. But the interesting thing was high ACE scores were associated with a lot of things in adulthood, metabolic things you wouldn't have expected, metabolic syndrome, obesity, that sort of thing. But ACE scores were very highly associated with the development of illicit drug use. And you can see this is the odds ratio. Once the ACE score gets to 5 and above, of drug initiation before the age of 14 and of ever being addicted. So the ACE in this calculation accounted for 1/2 to 2/3 of serious problems with drug use in these individuals. So, what is it about early stress? And again, this is another area where we're so lucky to have these wonderful animal models. It's like I say, it's harder to model bipolar disorder and depression, I think, than it is substance use. And so one of the things, Michael Meany and his group have done some beautiful studies where they, in rodents, and there's a lot of primate studies as well, but the stressor is removing a rat pup from the pack, the litter, for like 2 to 3 days during a critical developmental period. Then you put them back in the litter and they live and hang out with their, with their siblings. And then in adulthood, so 2 years later, you bring them in and test them. And one of the things that we know about those animals that were stressed early, they have higher basal circulating cortisol. Their response to a stressor is increased, both biologically and behaviorally. And what we're looking at right here, we're looking at dopamine release in the nucleus accumbens, an area we know is very important in the development of addiction. Dopamine release in the nucleus accumbens after a stressor. And you can see the lower line here is the group that did not experience any stress. The upper 2 lines, one is a group that was somewhat handled, another group not handled at all. But both of these 2 upper lines are animals that experience that early childhood period of stress. And if you give them cocaine, they have an increased dopamine response to cocaine and an increased behavioral response to cocaine. So again, remember this, to me, this was just amazing. 2 or 3 days of isolation as a pup. 2 years later, they are much more. The other thing about them is they're much more likely to self-administer cocaine if you just make a lever available to them than any of their peers. So something in that brain changed in a way as a result of that early deprivation to make these animals in adulthood more sensitive to stress. And their biology more sensitive, and their brains more sensitive to cocaine and more likely to take cocaine. So, this is part of the big question here: is how do these events that occur in childhood impact the response to stress and drugs later in life? And certainly, epigenetics is going to be the big answer here. As you all know, environmentally induced changes in DNA expression. These DNA, the double helix bonds are very tightly coiled, but at these histone bodies at the end, you can actually either methylate or acetylate them, and you can loosen the tightening of the bonds or tighten the bonds so that the protein is more, or that this is encoding for, is more or less likely to express itself. And when we think about the stress system and where might epigenetic changes in the stress system be that would impact drug use, you certainly would want to look at the HPA axis and CRF. The CRF, the genes that encode for that have some very interesting polymorphisms that seem to relate in a significant way to the development, vulnerability, the development of substance use disorders. But let me just show you this one interesting fairly recent rodent study. They did subchronic variable stress, both males and females, and found markedly different patterns of stress regulation and gene expression Females showed more signs of depression in these animal models. That's just sort of not moving much. But they also, when they sacrifice them, look at their brains, much greater methylation. So then they treated with DNA methyltransferase. They used a knockout mouse that had no DNA methyltransferase, so couldn't do the methylation. And in females only, this enhanced the resilience. So that tells us epigenetics probably had something to do with the impact of stress for females especially, and that unfortunately, we haven't been able to manipulate these epigenetic changes in humans yet, but I think it's got tons of potential. And I just wanted to show you, this is some really striking data, one of probably 10 studies, looking at polymorphisms of the CRF receptor. So again, I think probably the relationship between these polymorphisms and epigenetic changes is that certain polymorphisms make a gene more susceptible to epigenetic changes. So what we're looking at here, let's call it the vulnerable and the unvulnerable and the resilient form of the CRF gene. And this is a large cohort of Swedish individuals. And we're looking at the lighter bars are those who didn't have many negative life events. The dark bar is people with over the mean number of negative life events. And what we're seeing on the y-axis is lifetime heavy drinking. And so you can see, so if you happen to have the resilient carrier T polymorphism of the CRH receptor and a lot of trauma, it didn't really impact your lifetime risk of heavy drinking. However, if you've got the vulnerable, the homozygous form of this CRH polymorphism, and you don't have any negative life events, you're not going to drink any more than the people with the other form. But combined with a negative life events, you can see the development, that doubles the risk of percent lifetime heavy drinking, which is pretty much the development of an alcohol use disorder. So really a classic kind of gene by environment relationship that's been shown, in at least 5 or 6 studies to date. So bottom line, addictions, like most complex disease states, it's really not going to be nature or nurture. Nature plus nurture is really what we're going to be looking at, and those fine interactions between the two. So I thought it would be helpful maybe if before I leave, I spent about 10 minutes just talking about treatment rather than just talking about how negative this situation is and what are we going to do. There are some things, and there are some treatments right now that are very specifically targeting that stress substance use interface. But I have to tell you, when I first got into this business, and that was a long time ago, 35 years probably, there was very little empirical evidence to guide treatment. In fact, the bottom line, I was interviewing person after person. This was during internship and residency. Some of you can probably relate to that, with addictions, about their life histories, and I was blown away by the amount of trauma and the lives that these folks had led. And I thought to myself, and how many really had symptoms of PTSD. So I go to my and that was some of my first publications, was just sort of the descriptive, 100 substance users and what was the comorbidity. So I went to the literature. What do we do with these people? And basically, and talked to my supervisors, and they said, no, we don't deal with trauma-related issues in substance use treatment, because that you bring up those memories and that's going to prompt their relapse. And so I said, well, I think the memories, my point was, we're not bringing up something these people don't remember. These people dream about this every night. They're thinking about it all day long. When we ignore it, we don't get a therapeutic alliance. We can't maintain a therapeutic alliance with someone who's troubled by a rape or a horrible beating or something else, and we won't even talk to them about it, So then we go to the PTSD program and said, will you take these people? I think the PTSD is really problematic. No. PTSD programs at that point wouldn't take anybody with an active substance use disorder. So all the literature back then just showed that these were early dropouts. They did not stay in treatment. They were some of your worst patients, and it's not a small number. So to us, this seemed like a really big problem. And that's why I got together with Edna Foa and Kathy Carroll from Yale and Sudie Back and I, and we developed a manual that combined cognitive behavioral therapy relapse prevention with exposure-based therapy. And we tested it even though everybody said you shouldn't do this, but we tested it under very safe circumstances. And we have very good data, but I'm not going to talk a lot about that today. I'm just going to talk about the fact that, so over these last 30 years, I'd say there's been tons of progress and many, many, many studies. We weren't the only ones recognizing that trauma was a huge problem for our substance use patients. And now it's gotten to the point that really the feds recognize it, and SAMHSA actually has 6 key principles of a trauma-informed approach. Again, I don't want to make this a history lesson, but when you're as old as I am and you've been around, you do have to tell a few stories. So when another thing that used to be just so predominant in substance use treatment settings was really confrontational, like somebody saying, you're not facing, people would yell at each other, you're not facing your addiction. And even the counselors and stuff were pretty mean, and he said that these groups, I'd leave them and I'd just be, tense about, to me, that never felt like, I'm sure some people really, that confrontational approach actually can be helpful, especially if people are really with a lot of antisocial personality disorder and just trying to get out of everything. But that's not the majority of people in treatment. That really isn't. And so we have evolved towards a much kinder and gentler, not that we put up with a lot of bullshit, but a much kinder and gentler form of treatment. And this is what SAMHSA calls trauma-informed care. And the key, it's really principles rather than a particular approach, but basically it's ensuring safety, trustworthiness, transparency, peer support, collaboration rather than an empowerment, and recognizing cultural, historical, and gender issues. So substance abuse treatment really has changed over the last 30 years, and mostly in a good way, I think. But in addition to that, just sort of general trauma-informed care, there have been the development, there's probably 10 developed now, different PTSD, substance use disorder, behavioral treatments. And these are just some of them that if you look at the SAMHSA website, if you're interested, they're all on the SAMHSA website, all have some evidence, some more than others. Ours is COPE, concurrent treatment of PTSD and cocaine dependence, but of course we've now expanded it to all substances of abuse. And we actually got I think we have some of the best data. We did have something published in the New England Journal of Medicine last year, an Australian collaboration, very large group that was treated with COPE. So, but there remains a controversy in the literature, just so people, or in the field, not so much in the field, and that is the exposure-based therapy. That's what COPE is. We actually take people and it's designed to help people confront their feared objects, situations, and memories in a safe and therapeutic manner. And if you look at, the Institute of Medicine did a review of therapies, treatments for PTSD in general. The psychotherapies, really, the effect size for psychotherapies is much larger than the effect size for most medications. And exposure therapy was what they considered the gold standard in terms of treatment for PTSD. And I'd have to say, for us, when people can tolerate COPE and get through the manual, their symptom resolution is much more, they get much better symptom resolution than people that go through non-exposure-based treatment. But non-exposure-based treatment really involves mostly cognitive behavioral techniques, new thought patterns that support safety and recovery. And there are some people, my bottom line on this is there are many promising approaches to PTSD and substance use disorder. People shouldn't have to learn 15 different ways of approaching it. There's probably some active ingredients that we need to be able to consolidate and figure out what they are. Exposure therapy really is the most effective for the core symptoms of PTSD, for sure, especially the intrusion, the nightmares, that sort of thing. But not all patients are ready for exposure therapy, and especially not all patients with addictions, and not all therapists are trained in exposure therapy, and you really do need training. So I think what we really need to do is have the best treatment for an individual patient at their particular point in illness. So really a more personalized medicine approach, but just to rest assured, there are a number of approaches for this now, for this very difficult patient population that we used to really just pretty much ignore. Lots of medication treatments as well. And I'm not going to ask you to look this over, but I just wanted to put this up because this is a very nice, this Petrakis and Simpson review is, it's a few years old, but it really is a very nice review of pharmacotherapies. And I'm going to just give you the punchline. So they really focused in, they've only got, I think they've got 11 studies here. There's been 2 or 3 more. So there's probably about 14 well-controlled, placebo-controlled studies of pharmacotherapies for PTSD plus substance use disorder that I think would meet criteria to make it into a meta-analysis. And the bottom line from this one is there was modest improvement with the serotonin reuptake inhibitors and with adrenergic agents. Those were the 2 main. They actually did use a CRH agonist, no effect at all. People think that's probably, or antagonist, that's probably just bioavailability. But agents targeting alcohol consumption, like naltrexone and disulfiram, improved alcohol outcomes. So we really need to be more aggressive about, in alcohol dependence, using medication treatments. We often don't think about them. Disulfiram actually improved PTSD symptoms as well. And I don't know if you guys know, but disulfiram, it's that drug, it blocks alcohol. It blocks acetaldehyde dehydrogenase. So that's the enzyme that takes alcohol, that takes the acetaldehyde and detoxifies it. So what happens with disulfiram is there's a buildup of acetaldehyde, which is a very toxic and nasty chemical and an unpleasant experience. But disulfiram also blocks dopamine beta hydroxylase, and that's the enzyme that transitions epinephrine into dopamine. So what you get there, dopamine into epinephrine. So what you get with disulfiram then is an increase in dopamine, which should help people with addictions, and a decrease in norepinephrine. And so that's probably why it improved PTSD symptoms. So there's further studies of that going on. Then in this, there are also 2 very small studies, pilot studies with agents that target both PTSD and substance use. And that was a study of topiramate done by Steve Botke and a study of N-acetylcysteine that was done by our group. And in both of these studies, there was a trend towards improvement in both disorders, and they're both being followed up with larger scale trials. And let me just tell you a little bit about the NAC trial, since that was ours. NAC is actually available over the counter, and acetylcysteine, it is it acts via the glutamate system. It downregulates the glutamate transporter. And we think glutamate is very involved in sort of the memories that people remember about both stress and drug use, that lead them back to drug use. So we've done at MUSC, this is the top is a trial of NAC in cocaine dependence, and you can see this is relapse prevention, days to relapse. The high dose actually much improved days to relapse. The lower dose, looks like a dose dependent manner. The bottom graph is a study by Kevin Gray looking at marijuana use in adolescents, NAC plus contingency management. You can see increased negative urines. Unfortunately, we tried this in a multi-site trial and we didn't see this nice effect that we see here with the adolescents. And not all of the cocaine NAC stuff in larger trials has turned out either. But Sudi back to try 35 veterans, PTSD, SUD, randomized to NAC daily, 8-week study. We looked at the caps for PTSD and then craving and drug use. They all got weekly individualized CBT. And this is the data. You can see spontaneous craving with NAC versus placebo. And this is the CAPS total with NAC versus placebo. We did not see a difference in drug use because all of these people were in a halfway house. So drug use was prohibited, but craving. And so now Sudi's got a multi-site study going on to see if we can, if this effect holds out. And then Steve Botke also conducting a larger trial, but his was a 12-week placebo-controlled, 300 milligrams a day of topiramate, and the topiramate decreased the frequency of use and craving, decreased overall PTSD symptoms. Of course, it's associated with some cognitive effects that aren't so nice, learning and memory problems, but as a proof of concept, I think it was a very interesting study. One last study, just in terms of looking at stress-induced relapse and the adrenergic system. This was from the intramural program at NIDA, opioid-dependent subjects on MOUD, buprenorphine, randomized to adjunctive placebo or clonidine. Clonidine, as you guys know, is an alpha blocking agent. And then they used EMA to ask people repeatedly during the day, are you craving? What's going on? Are you feeling stressed? What's going on? Have you used? So there's ecologic momentary assessment. And what they found was interesting. This is the clonidine, is that green line, relapse prevention. Again, clonidine, actually adding clonidine did show some advantage, less likely to relapse. And when they did relapse it, they had a longer period of abstinence as compared to placebo. But what was especially interesting is when they analyzed the EMA data, the clonidine group reported much greater ability to resist use and much less drug craving under stressful circumstances. So the stress relapse connection was sort of loosened in this clonidine group. We are now, of course, I asked Kinsey Preston, the group, can we do a gender analysis of this? Because again, back to our human laboratory data, we would think this effect would be particularly strong in women, but they didn't have enough women. It's mostly male group. So we are now looking at this, a similar study. We do some human laboratory stuff first, but we're looking at lofexidine in people on MOUD, men and women, and our hypothesis is that lofexidine will be, which is another adrenergic blockade, and where our hypothesis is that it will interfere with stress-induced relapse, and particularly expecting a strong impact in women. So I think with that, I've just got a few concluding slides and then a minute or two for questions. There's a profound relationship, I think, between stress and trauma and substance use disorders, that really stressful life events appear to be able to facilitate the initiation of substance use. They certainly appear to, again, as particularly childhood stressful events, increase the risk of developing addiction after one has initiated use. And they appear to be able to trigger relapse. 3 very important points. In terms of clinical considerations, I think we just need to have a very careful assessment and aggressive treatment of co-occurring stress-sensitive disorders in people with substance use disorders. I didn't show you, we do have some oxytocin data, and especially with oxytocin, social support is particularly important in combination with oxytocin in mediating the effects of stress. So, and that's really what AA and NA and a lot of those peer support groups are all about. It's social support, and it's very helpful in preventing relapse. need careful attention to environmental factors like ongoing stress and abuse. And we really need to stress more of the coping skills and stress management techniques in our substance use treatment settings. So again, I think the assessment and treatment of trauma-related psychopathology is critical in order to have successful treatment of people with substance use disorders. We have psychotherapies for sure. We've got a handful that are very useful. Pharmacotherapies, there's some promise there. Even though the effect size for these is very small, it's probably worth a try, with the idea in mind that they don't work for everyone and you'll stop them if they don't. But I think it's I think pharmacotherapy, and there'll be new developments, I think, in the pharmacotherapy area. And with that, I will finish up and happy to take any questions. Okay, somebody asked to share the New England Journal 2020 citation. Okay, oh, that's Lisa Nadjevitz. Hi, Lisa, how are you doing? I'll definitely, I don't have it right with me. I'll share it with you, and I'll share it with Kim, and she could send it out to anybody else who's interested. Kim, I think you're
I'm muted, sorry. So it was interesting to see, the sex differences in your data, and you kind of made a nod to perhaps this could be one of the biological underpinnings of sex difference, or it could lead to differences in PTSD. And I think it's just worth noting that even given the same stressors, women are far more likely to develop PTSD than men. There has been this debate, is it the type of trauma that women experience versus the type of trauma men experience? But I think these findings really speak a lot to, is there some sort of biological vulnerability? And I don't know if you want to say any more about that.
Yeah, I mean, I think that's definitely a possibility, and certainly and if we think about the early childhood trauma stuff and the types of trauma that are most like, a part of that really is about trauma type, and sexual trauma is certainly more devastating. But I do think women have greater vulnerability via two avenues. One is, I think they are subjected to trauma types that are much more likely to be potently associated with the development of PTSD. But I do think the adrenergic sensitivity, and if drugs of abuse can do this, can sort of prime that system in that way, surely there's other ways in which that adrenergic system in women is different and more sensitive and more prone to epigenetic alteration, or whatever that is that goes on, that leads to the development to vulnerability for both PTSD and substance use.
Very interesting. I would add that we did a study looking at progesterone treatment for pregnant postpartum women with cocaine use disorder after delivery. And similar to your data, we saw the rate of relapse go way down for cocaine specifically.
Really? That's
in postpartum women. I mean, the study was cocaine, but it does seem that there's something about about stimulant related disorders. And we know that cortisol binds to some of the same receptors as progesterone. So, there does seem to be a lot of connection between those systems.
So I've got another question here. Dr. Rothschild thought the disulfiram study was of interest, and it really, I agree with you. I think that's really interesting. And disulfiram's use has declined. Maybe you should use it in PTSD patients with alcohol misuse. I think if people are fully informed of what's going to happen if they drink, I think definitely it will decrease. There was one small study, and then there's been a larger study that's done since then. But what was so interesting is, since there's another drug that was under development, was called napikistat. And it was a drug that just blocked dopamine beta hydroxylase and didn't have the acetaldehyde. So it would be like, okay, so if you just wanted to treat PTSD and not, have that toxic interaction with alcohol, but it was not they tried it in a VA setting, and it turned out to be not efficacious in PTSD. No idea why. But that disulfiram data stands, and it's not the only, that one study with PTSD is there's one small study, one larger study, and then a couple of studies of people with cocaine use disorder without PTSD, where disulfiram seemed to act, was efficacious in decreasing cocaine use. And again, they think that was the increase in dopamine.
Yeah, it's very interesting. Well, listen, thank you so much for a wonderful talk. I know Dr. Yonkers had to go to a meeting, but this was absolutely very interesting and informative. Thank you.
Thank you. Nice to see you all.
Thank you so much.
Okay. Happy holidays, everybody.
You too.